So mechanical alignment is something which I have done in the past. I continue to do it today and probably might continue to do it in the future, but I'm not sure. We all know that the mechanical alignment is something where you want a 0, 90 degree cut to the femur, 90 to the tibia, the mechanical axis, and this is what the X-ray should look like. A center of the hip to the center of the ankle should go to the center of the knee. And we have known for sure that a poorly aligned knee can result in disastrous complications. But this being said, we have now come to talk about various alternative alignments. And in this session, we will have Krishna speak on unrestricted. We will have Vikas speak on restricted, functional alignment by all the speakers here. Anup will speak on functional. So I think I would like to just make a statement here that if you're attempting to go for a mechanical alignment and you end up with some other alignment which you don't know, then you are probably aiming for a disaster. But if you plan, and I'm not saying these alignments are something which you should never think about because I am a mechanical guy, you should. But then you should make sure that you get your desired alignment. So for me, mechanical alignment is something which is very easy, and that is what I follow. In the next half an hour, 45 minutes, you will see the entire gamut. I still follow mechanical alignment, and that is what has worked for me. In 2010, Howell told us about the unrestricted kinematic, where you basically prioritize the femur, the femur alignment is sacrosanct, but you can play with the tibia. That became the inverse kinematic. You play with the femur. Restricted is with selective boundaries. And now I think Faraz Haddad is something who talked to us about the functional alignment, and that is what many people follow. I am not sure whether that's the way to go. The people who practice kinematic alignment very dogmatically, blame the failures that, oh, this is a mechanically aligned knee, this is now how the alignment should be, and that is the reason for failure. Well, that is something which I am not really very comfortable with. All dissatisfied patients may not be unhappy because of the wrong alignment. There are many other reasons which are there for dissatisfied patients, and the entire list is mentioned here. So you cannot blame an alignment that, okay, this is mechanical, this is bound to fail. There are 9 CPAC types of classifications and the joint line variability. So you have to not think of one alignment for one person. I agree with that. But that being said, there are other causes of failure. Don't blame everything on the mechanical alignment. In India, we treat severe deformities, and when you have severe deformities like this, it's very difficult to reproduce the native anatomy. And then that is why I feel mechanical is something which has worked consistently, and that is what I would like to do. As I said, the distal femur is cut perpendicular to the mechanical axis, proximal tibia again perpendicular to the mechanical axis, which is similar to the anatomical axis, and you get the appropriate rotation. For me, the sequence is I first balance in extension, do the soft tissue release, and get a balance in extension. In flexion balance is by rotating the femoral component parallel to the tibial cut technique taught by Ranawat. That is what I do, hardly any soft tissue releases. And then once you've done the distal femur, the proximal, you should know which cuts affect which cuts, and the proximal tibia will affect both the gap in flexion and extension, so appropriately you take the cuts. And we have been flooded with papers before these alignment technologies and alignment alternatives came up that a poorly aligned knee will fail, and this is one of the famous papers by Merrill Ritters, which showed a significant failure rate if the tibial component was in more than 3-degree varus, and that is what our alignment colleagues are going to tell us. It also is leading to failures because the varus tibial alignment can cause early loosening. That has been told to us. And if you see the pillars and the pioneers who have shown excellent results, survivorship at 17 to 20 years, 94, 90% plus. So why are we challenging this? The data is still not out, the jury is still not out, and probably in another 5 to 7 years we would know. So do we use kinematic alignment for revision knees? Is there any talk on that? Nothing. When you're talking about revision knees, you're putting them into mechanical. So why not put your revision knees also in a kinematically aligned knee? So how do I perform my TKR in 2023? I still use the conventional instruments and jigs. We have 3 robos in the hospital, but I would prefer my colleagues, Sunny, Kailash and Sahil, to use the robos. I would rather do it conventional, to be very honest. But we have to have it because Pune is the robotic capital of India, 23 robots. So every second patient will ask, so that's why we have 3 robots parked with us. And I am a believer of the gap balancing parallel to the tibial cut technique. But let me be very honest and tell you how has the alternative Suhas, and I do not hesitate to accept some residual deformity which I know is there. Do we call it the adjusted mechanical or varus deformities? Then you adjust on the femur so that you can alignment strategy. You know, you will consider. As of now, maybe after this session I will change, but as of now, there's no compelling reason for me to.
4 points. Slope side, you must use some sort of a guide to replicate the native slope, and you have to replicate the medial sided slope because you're trying to preserve the CL. On the femoral side, the sagittal orientation is replicated by using action that is tried to replicate. And you reference of the unaffected condyle, removing 8 to remove a varus positioning in a mechanically aligned TKR, then the failure rate is much higher in terms of gaps, thereabouts, lateral slides, and this must be respected as to which slope you must try to replicate, and also of early failures of kinematic alignment, the problems with the posterior tibial slope.
So, tips and take-home messages. We have all the 4 panelists here who will help us do that. A myriad of alignment strategies. So you have unrestricted KA, you have restricted KA.
Important awards after these 5 in primary total knee arthroplasty, 2 years follow-up, similar functional and clinical outcomes between mechanical alignment and kinematic. This is the John Insall Award paper, and multiple factors are responsible for pain and outcome after total knee replacement at 5 years. The musculoskeletal factors can be modified. Aspirin is associated with a lower PGI rate, and it can be recommended as the gold standard when you want to do primary total knee replacement. As of now, as per the authors and as per the 21 RCTs, robotic assisted TKA, they just have accuracy. Only the mechanical accuracy on radiographs are, as per planning, is better than conventional, but functionally both robotic assisted and conventional TKA do very same. They do in the short term, there's no superior outcomes. So the last slide, what is a landmark paper? You know, there are so many papers, but it is best for us to extrapolate what is good for our practice. But most importantly, one of the mistakes, especially when we, from this part of the region, we do is we only read the abstract of a paper and we come to conclusions. It is very, very important you make the effort to download the paper, get the paper and read through it, and then you get an essence of what the authors intend to say, and there are a lot of finer points which you can get and improve in your practice. Thank you for your attention.
I think the discussion is later, Raja. Yeah. So there's about 15 minutes for that. So we'll go on to the next one. Invite Dr. Sahil to come and speak on the 5 landmark papers on uni.
Good afternoon. So I'll be talking on the 5 landmark studies in the last 5 years on medial unicondylar knee replacements. So what are the major concerns regarding a UKR? It's the ACL, the patellofemoral joint, cementless unis, joint awareness, and higher revision rates. So to address these concerns, I've scouted the Journal of Arthroplasty, CORR, JBJS American, and British on these topics over the last 5 years. Number 1, how does the ACL impact your uni? This paper, published in the Journal of Arthroplasty, which was the Lawrence Dorr Surgical Techniques and Technologies Award, tried to look into this. In this study design, they had 176 medial unis, a fixed bearing design, and they compared ACL intact knees versus those where the ACL was deficient. And what did they find? They found no significant difference in the KOOS scores between ACL deficient knees versus ACL intact knees. And overall, there were lower failure rates and excellent long-term results in the ACL deficient unis as well. Of note, in this study, in ACL deficient knees, the tibia was cut at a 0-degree slope to try to minimize the anterior tibial translation. Number 2, the patella, which is always the bone of contention. In this study published in JBJS, which was the influence of preoperative radiographic patellofemoral degenerative changes and malalignment on unis, they looked at the patellofemoral joint arthritis and they assessed it based on the Altman score, and patellofemoral alignment was judged by the patellar tilt angle and the congruence angle. They excluded those cases where there was severe bone loss or grooving of the lateral patellar facet. And what did they find? They found that degenerative patellofemoral joint changes, the patellar tilt angle, and the patellar congruence angle did not affect the Q scores, satisfaction, or PROMs, and thus they concluded that patellofemoral joint degeneration should not be considered as a contraindication for medial UKA. Number 3, cementless implants are coming, so should we take the leap of faith and adopt them? This study, a matched comparison of implant and functional outcomes of cemented and cementless unis, was published in JBJS last year. They looked into around 6,900 unis, which were from the National Joint Registry of England, Wales, and Northern Ireland. They had an equal matched cohort of around 3,500 cemented and cementless unis, and the outcome was survivorship and Oxford knee scores. They found that in the cementless uni group, there were better functional outcomes, improved survival, and significantly lower revision risk. And interestingly, as has also been told earlier, that surgeons who performed more than 30 unis a year actually had the best results and the lowest complications. Number 4, joint awareness, the holy grail of the forgotten joint that we are all in search of. This study, published in the Journal of Arthroplasty, looked into joint awareness and function when comparing total knees with partial knees. This was a matched cohort with a minimum 5-year follow-up between UKAs and TKAs. All the unis in this study were robot assisted and the total knees were a cemented PS design. They found that partial knees had significantly higher forgotten joint scores, higher knee society scores, lower numeric pain rating scores, and lower joint awareness. So now while all these results look encouraging, you're wondering, UKR has higher revision rates. So what about that? This study, which was a comparison of clinical thresholds for revision following total and unicompartmental knee arthroplasty, published in the BJJ, tried to look into this. So the aim of this study was to compare the clinical thresholds for revision. I'll say that again, the clinical thresholds for revision between a UKR and a TKR based on the revision incidence and the Oxford knee scores at 6 months, 5 years, and 10 years. And what did they find? In patients who had poor Oxford knee scores, which was defined as a score of less than 25, if those patients had a uni, there was significantly more revisions. But in the same patients who had poor Oxford knee scores, those that had a total knee replacement actually had much fewer subsequent revisions. And they concluded that more revisions in a uni rather than TKR were actually for unknown reasons, and that higher revision UKA rates were associated with lower clinical thresholds of the surgeons. And I think this is largely because if you have a poorly functioning patient with a uni, it's easy to tell them, let me revise you to a total knee. But if you have an unhappy total knee, you're going to think long and hard before offering a revision to that patient. Thus, to summarize, the anterior cruciate ligament and the patellofemoral joint did not seem to affect the outcomes or the PROMs after a uni. Cementless designs had better function compared to cemented partial knees. Joint awareness was much lower with a partial knee as compared to a total knee, and the higher revision rates were largely attributed to lower revision thresholds amongst surgeons. Thank you for your kind attention.
Please take a seat, Sahil. Next one is by Dr. Sasinder. May I invite him, please? 5 landmark papers in management with orthobiology.
Good day, everyone, and thank you very much for this wonderful opportunity to speak about landmark papers on orthobiologics. I'm Dr. Sasinder from Chennai. So, orthobiologics includes too many things inside that one word. So, there is too much for me to discuss. So, I will try to cover what I think could be impactful. I'll start with a bit of history. Urist was supposedly the first one who identified something related to orthobiologics. He identified that demineralized bone matrix can help in new bone formation. That was called as autoinduction. Subsequently, Kaplan AI proposed or formalized the concept of mesenchymal stem cells or multipattern stromal cells that could be capable of differentiating in bone and cartilage. However, the same Kaplan in 2017, later, he said that mesenchymal stem cells should not be called stem cells anymore, and they should possibly only be medicinal signaling cells because they work more as via paracrine mechanism, as in stimulating the localized mesenchymal cells rather than actually proliferating in the site that they are being used. So this is something that we have to understand. Moving on. Controversial or non-controversial, let us discuss about PRP for knee osteoarthritis. The RESTORE trial published in JAMA in 2021 has been of a lot of acclaim. It was a multicentric, double-blinded, randomized controlled trial that compared 3 PRP injections versus saline placebo injection and found no significant improvement in pain or MRI cartilage volume at 12 months. There are also other studies, for example, by Dorio et al. They have also found no improvement or difference betterment after PRP for knee osteoarthritis. So what exactly has happened? Have you been tricked all along? Have you been backstabbed and bamboozled? But if you get into the details of the paper, the PRP that was being used was 1.6 to 5 times more than the whole blood volume or whole blood values. But by definition, PRP has to have at least 5 times concentration in order to call it as PRP. So we have to be mindful of what we are injecting to our patients. That may not be even PRP. What comes out depends a lot on how you are doing it. So it has been proven without doubt that preparation methods change what comes out, the quality of PRP that is being produced. So, is standardization possible? Yes, a lot of papers have worked on that. Our own Satish Muthu and Buford have suggested ways and parameters that have to be addressed in order to standardize PRP preparation, and these need address. And there are a lot of studies that have shown high concentration PRP or high volume PRP have produced sufficient proof of better outcomes after PRP injection for knee osteoarthritis. As far as PRP is concerned, more appears to be merrier. So the consensus is we have to know what we are doing, what we are giving, how we are preparing the PRP. Moving along, I was just interested in umbilical cord based mesenchymal stem cells because if it was successful, it will lead to over-the-counter availability of stem cells, right? So let us try to understand what the literature says about umbilical cord-based stem cells for chondral defects, not knee osteoarthritis, for chondral defects of the knee. This is a study by Lim et al. They studied large full-thickness chondral defects of grade 4 in the knee. They used umbilical cord-based mesenchymal stem cells along with hyaluronate and compared it with microfracture, and they found superior cartilage repair versus microfracture, and this outcome was maintained as long as up to 5 years. So possibly there is still a lot of role for UCB. The repair they obtained arthroscopically and histologically as well, the cartilage repair appears to be good. So possibly we are going to be there in the near future over-the-counter stem cells for cartilage repair. However, it was not a blinded study because of ethical reasons, and microfracture was not the ideal treatment for the placebo group for large lesions. Moving on, what about osteoarthritis? Can the over-the-counter stem cells also be used for osteoarthritis? Will all the replacement surgeons go out of job in future? So there is a study by Parag et al. Who has studied MSc along with hyaluronate in comparison. Sorry, this is not a comparative study. This is a small study of 7 participants. They have done umbilical cord-based mesenchymal stem cells along with the HA for repairing the cartilage. The primary and secondary assessment parameters include ICRS cartilage repair, VAS scores, arthroscopy at 3 months, and VAS score again at 24 weeks, biopsy at 1 year, and MRI at 3 years. They have found sufficiently good outcomes with this treatment even for osteoarthritis, except for patients with actual severe deformity of the knee. So this treatment was not done for patients with severe deformity of the knee, that is grade 4 osteoarthritis. They limited to grade 3 osteoarthritis. So this is the kind of arthroscopy that they found, and cartilage repair by MRI also was good. Histology also showed a lot of good outcomes. This was a small study without control group, so this has to be taken with its limitations. Finally, we are trying to improve our ACL repairs over time, make it better, stronger. So biologic augmentation for ACLR, does it help? Study by Lin et al. Compared PRP versus BMAC and PRP versus nothing for ACL reconstruction. They could not find any improvement in outcomes after this treatment. So still possibly biologic augmentation is not the best treatment, best option along with ACL reconstruction. So take home message, no evidence is permanent, evidence keeps changing, so we have to be on the lookout for that. The PRP we use may not be PRP as such. We need to be mindful of what we are giving our patients. Over-the-counter MSCs may be not far away for arthritis as well. And there is currently no use of biological augmentation for ACL reconstruction. Thank you very much.
Please join us here. May I invite Dr. Anshu Shekhar for the 5 papers on osteotomy.
Thank you, sir. So, I think Dr. Raja very elegantly talked about what he thought are landmark papers. So, in my view, landmark papers would be those which have an impact on my clinical practice, which are clinical studies and not biomechanical analysis by themselves. They have helped change not just my practice, but discussions in such scientific forums and generation of scientific literature by their own merit themselves. So this is the first one. Now, the biggest problem we see with osteotomy, which we're realizing now, is they were done badly because they were planned poorly. And they were planned poorly because we had conceptions like 1 degree correction equals 1 millimeter, which we now know is not true. So this paper here, this is from France, from Mathieu Olivier's group. This basically compared the simple tool of using the Hernigou's table, which we can do intraoperatively. We don't really have to pre-plan. And they compared this group against another group which was planned using the CAS, which was navigation. Now what they found, those are the baseline characteristics. You see there is no difference at all. So what is basically the implication is using the Hernigou's table, which is completely free of cost, can be done intraoperatively, gives you accuracy in planning, which is as close to as with navigation. How this has changed my practice is now I use software-based planning, but I always, every single time during surgery, cross-verify what I have got with my software planning using the Hernigu's table. And I hope that as this is inculcated into everybody's practice, the results of osteotomy themselves will improve because we'll start doing more accurate work. The second paper, of course, this has been cited very widely, almost 80 citations as of yesterday when I was checking. This paper again compared using what are known as hinge wires. We've seen in the previous morning talks as well. Almost everybody here is using hinge wires. Now they compared two groups of patients of 60 patients each. One group which had a hinge wire, the other which did not have a hinge wire. For those from hardcore arthroplasty, if you don't know what hinge wire is, I'll show you this in 1 minute. So this is a hinge wire. This is a wire put very close to the hinge to protect a lateral hinge fracture from propagating and if it occurs from displacing. So Takeuchi, of course, classified these as type 1, 2, 3. Now this paper effectively demonstrated that putting a hinge wire basically reduces the incidence of lateral hinge fractures significantly. And the biggest reduction was in type 1 hinge fractures or in the occurrence of any type of hinge fractures at all. How this has changed my practice, I evolved from putting a hinge wire from distal to proximal, went on to proximal to distal, and now it is not very uncommon when I actually have started putting a hinge screw as well, which stabilizes the hinge, gives me the confidence to mobilize my patient faster. So another landmark paper based on biomechanics, but extremely sound and very highly cited. The third one is this. This again from Stefan Schotter from Germany, huge impact on our current practice in osteotomy. Now what these people basically did was, they were not the first ones. The first one was Babis, who published in 2002. This was in 2019. This was a retrospectively performed study wherein what they did was all patients who had severe varus osteoarthritis, and if their LDFA was anything greater than 90, MPTA was anything less than 87, and if they found that on preoperative software planning the MPTA would increase to 94 degrees, then such patients were categorized and they underwent a double level osteotomy, which is basically a medial open high tibial wedge and a lateral closing distal femoral osteotomy. Because this is again based on the premise that if you don't do this, then you would end up causing very oblique joint lines. The articular cartilage is very well adapted to take compressive stresses. It is not meant to take shear forces, and JLOs more than 5 degrees cause a lot of shear forces, which basically wears off the cartilage, will lead to failures of osteotomy surgery. So the surgery itself gets a bad name because it has been done in a technically improper manner. Now here again, look at those numbers. This is from this paper. The exact sweet spot, the MPTA at 6 weeks of 89 plus minus 2 degrees, the LDFA of 87 plus minus 2 degrees. That's bang anatomic as per Dror-Paley's philosophy. So again, how this has helped me is such gross varus osteoarthritis now is not unfrequent, wherein I am performing a double level osteotomy for them using small corrections in the femur, small corrections in the tibia, and getting very straight joint lines and not causing any obliquity at all. The fourth paper, of course, this I was very careful in understanding that none of these authors, these are from Finland, have any industry stake. So none of these authors have anything to do with either Arthrex or Tomofix, because these are the two implants that were compared in this study. So traditionally, when medial open wedge osteotomy started, it was the Pudu plate, that short plate which was used in everybody, and then of course Synthes came up with their Tomofix principle and design. Now this paper compared patients who had almost 200 patients, that is, who had undergone a medial open wedge HTU by either system, by either the Arthrex Pudu plate or the Synthes Tomofix, and they try to understand what is the survivorship of these osteotomies like. And look at those two. The graph on top is basically the locked plate or the Tomofix design. The graph below, the Kaplan-Meier survivorship, which goes on falling to 68% at 5 years and just 50% almost at 10 years is the Pudu plate. Therefore, using a locked plate construct such as the Tomofix, now there are many variants of that available as well. Using a long locked plate is better in terms of giving you better implant survivorship. The final paper, this is not really a core osteotomy paper, but that which has really changed osteotomy practice in one segment in an ACL deficient knee. Now 20 years of follow-up from Leo Pichinski's group from Australia. they have proven that posterior tubal slope really matters, and they have demonstrated in almost 180 patients who were followed up over 20 years. That's massive follow-up. And this is clinical data which shows the catastrophic effect of the age and a high posterior tibial slope on survivorship, not just of the ACL graft, but also of the contralateral native ACL. What they have found is when the slope is more than 12, there is very high failures, not just of the graft, but of the contralateral ACL. And when you add to that the effect of age, so any age less than 18 years, look at that, the one on the right side. Massive failures when you have slope of more than 12 and the age of less than 18. So again, this has impacted practice because 12-degree slope is not really common. This is again from the same paper as well. And that has led to resurgence, or rather the, really acceptance of anterior closing wedge osteotomies, whether it is transtubercular, supra or infratubercular. Thank you.
Please join us. Yeah, I think there's time for discussion. So I'll start with asking Dr. Sasinder. In the study which threw light on the umbilical cord based MSCs on ONE, not the one on the chondral defects, but the one on ONE, they showed that there is a increased cartilage layer formation. So does that mean there is a reversal of the stage of arthritis where it's going back from 3-2 to 1? Is that the inference?
Yes, yes, definitely. So, I mean, this is that's not what we want to believe, but this is what they have shown.
And in the PRP paper, initially you said that there was no difference between PRP and placebo, but then you went on to say that there was a problem in terms of concentration.
Yes.
So does that also mean that with a...
Yes, by definition, PRP has to have a platelet concentration of at least 5 times of your whole blood platelet concentration. So centrifugation preferably has to be dual centrifugation. There are soft centrifugation methods, single centrifugation methods that give like 1.5 to 2 or 2.5 times. The PRP amount is not sufficient enough to create an impact. The other concept is super PRP or high volume PRP. Super PRP is a brand. Let us not use the term high volume PRP, because the more blood you take, whatever be the concentration index that you achieve, the final volume of platelet is higher. So the amount of mediating factor that are released in the site are higher. So they are supposed to work better.
Yeah. Questions from the delegates?
Can I just make a comment? I think the word landmark here can be subjective or objective. If you look at it objectively, it could be this number of citations for an older. I think the 2 sections here, they have not we have not given any time limit, so they can be from the beginning. I think he is right. Arnal Kaplan's.
We had given them a time limit of 5 years.
The first 2 sections had 5 years. So in those cases, citations may not work because citations take time to accumulate. So alternative metrics like alt metrics can be used to identify which papers are a landmark. That's objectively measuring. Subjectively, if it changes your practice or fills a major gap in your knowledge, I think that's a way to identify.
Regarding the stem cells, is there any journal, any association or any national medical society which has recommended or approved the use of stem cells for any orthopedic condition?
Can I comment on this? I think there is, for orthobiologics, SKA has come out with 2 good papers, SKA Orbit 1 and 2. One is for blood-derived products and 2 is for cell-derived products. And these 2 are, I think they are very good papers to be included in your list.
As far as your question, I'm not sure if we need the approval of any national orthopedic body to approve the stem cells.
It's
as
not-
long as
see,
the
one-
evidence is available.
There are two things. One is the approval for the use, other is recommendation by the society that this is definitely useful.
Yeah, evidence says it is useful. So we don't need the approval of orthopedic bodies to say that it is useful.
In which condition? In which
There are
orthopedic-
specific indications for specific stem cells and the grade of the condition. I cannot, I don't want to generalize it. There are specific grades or specific conditions for the stem cells.
I think the next session also is on orthobiology, so we can discuss more.
Dr. Jurani and Dr. Tapasvi are waiting. Yeah.
Yeah, so Raja, in your first paper, the John Insall Award paper, you talked about reading the paper thoroughly.
Yes, sir.
So, in the discussion, it's mentioned that in CPAC 1 and 2,
Yes.
there may be merit in not correcting them fully.
Yes, sir.
And leaving some residual varus.
Yes.
So those are the patients which had higher functional scores in the FA group, the CPAC 1 and 2. So I think, that deserves attention, because not correcting varus deformity to fully straight limbs may improve the scores.
Exactly, sir. So that is one of the points. I completely agree with what Dr. Anup sir was saying. You have to read through like all the four, whether it's orthobiologics, osteotomy, TKR. Reading through an entire paper, you get to understand the exact philosophy of the authors and what they also want to discuss. And some authors also discuss the limitations in specific. So that is the thing which came that, when you are planning to do kinematic alignment, it is better in varus knees not to go more than 6 degrees, and in valgus knees not more than 3 degrees of valgus. That's what inferred from that paper, and that doesn't come in the conclusion. It comes when you read through, and as sir was saying, in those parts of CPAC, you get that part of alignment. Thank you.
Raju, you talked about a paper where double level osteotomy was advised. Now, if you read that paper is not based on any cadaver study or live patient study. It is a study based on finite and element analysis. Yes, I've read that paper. That paper is based only on computational, and it talks about shear stresses on the articular cartilage. And the later studies have shown, which are published in the American Journal of Sports Medicine, that even if you have a joint line obliquity, it doesn't affect your clinical results. So this paper produced two inferences. Either you do a double level osteotomy, both in femur and tibia, or you do a UKR.
So the paper which I presented by Stefan Schroeter is a clinical study. It is not a finite element analysis. The inference of 5 degrees JLO causing shear stresses is a finite element analysis. That is not Stefan Schroeter's paper. This paper which I presented is a clinical study. I have the full text. I'll be happy to share it with everybody, all my papers.
But now the studies have been published that the joint line obliquity doesn't matter at all. You can have joint line obliquity and very well have good results. That's published in many, many journals now.
In fact, they said we want to reproduce joint like JLO. That's
Sorry?
the
If
whole
you
thing.
have your JLO which is more than 5 degrees,
Yes.
then you have poorer outcomes of your ACL, and there is a threefold increased risk of conversion to
About 3
TKR.
degrees is what you want. What is
Sorry?
the magic number? So what amount of JLO is acceptable to you? If you
when
see
you-
the type 1 classification of CPAC, you want that joint line oblique apex downwards.
No, that is...
So that
in the-
is something
in the
which, unless you create a joint line obliquity, how will you get that?
That is an arthritic knee where you're using a prosthetic joint. This is talking about restoration of JLO when you're doing an osteotomy. You do not want to keep the joint line oblique. So essentially what that double level osteotomy is, that if there is deformity in the femur and the tibia, and you correct everything in the tibia, the limb looks straight, but the joint line is completely oblique. So the proximal tibia apex is facing up and it is sloping downwards, which then leads to shear on the cartilage. And this JLO, when you increase your MPTA beyond 95, so when the MPTA goes beyond 95, this becomes a disastrous situation for the long-term survivorship of the osteotomy.
So is Krishna here? We were asking for you, Sachin, when we were talking about this particular paper, which you said that, where you should correct on the femur also. But Krishna was saying that if you touch the femur, the kinematic goes to a 6. So you cannot really touch it. Yeah, arthritic knee or non-arthritic knee, but principles cannot change.
No,
So
principles will change because the treatment modality is different.
No, the basic principle of kinematic we were
So
talking.
it is like saying that when you, like yesterday when we spoke about doing an osteotomy, why do you want to correct it to neutral or over-corrected? I think Ravi only pointed it out yesterday, correct? That because the treatment endpoint, that was your answer given, if I remember correctly. That is what you replied yesterday, saying that because the treatment modality used is being different, every treatment modality has a ideal sweet endpoint.
No, I didn't say
Not,
that.
it wasn't you. Who was it? I forgot. Anyways. Krishna said it.
Krishna
Because
is the one who
person
causes
right
all the
context-
controversy.
Krishna, correct. You said yesterday that it was your very logical comment which I wanted to hear, saying that depending upon the treatment modality that you choose, each treatment modality for it to be successful has a sweet spot, and that is why you have a certain alignment philosophy for what you want to use, correct?
That's right.
Yeah.
We should also prevent the failure.
Prevent the failure, absolutely. So Anshu, my question to you is that on the hinge wire paper, there are a lot of osteotomies done previously. Is there a limit beyond which you have to have a hinge wire? So is there a limit on the distal femur, closing or opening? Is there a limit on the tibia, opening, where a hinge wire is a must?
Yeah, so for the femur, we know that, for the tibia, we know that hinge fractures incidence rise several fold for any openings greater than 11 millimeters. So if you are planning any opening greater than 11 millimeters in the tibia, a hinge wire is must. For the femur, I am not aware if there is any threshold for how much correction needs to be done. I think it is 9 degrees. It's on the medial side or lateral side, I don't remember correctly, but 9 degrees of correction, they have 9 millimeters of wedge they have recommended for the femur. Also to add to Parag sir's comment, sir, I think the concept of JLO and JLCA are different. Currently, there is a lot of misunderstanding between osteotomy and arthroplasty surgeons about JLCA and JLO. And the second thing about overcorrecting osteotomies. So the only time that I have seen a CPAC 9 knee was a post-osteotomy knee, corrected completely to valgus and apex proximal. I don't know if naturally anybody has ever seen a CPAC 9 knee physiologically. So badly done osteotomy can lead to a CPAC 9 knee. Otherwise,
That is the whole reason why we formed this society, We have to have some consensus between arthroplasty surgeon and the sports surgeons.
Last question, quick question to Dr. Anshu about the plates. Last one, sir. About the plates for the osteotomy fixation. What is the rationale in the sense, irrespective of the plate, why has that got anything to do with the survival? Because once the bone heals, there is no utility of the plate hardware at all.
So there are 2 points. Number one, if at all a hinge fractures, then the chances of non-union are much higher if you're using a non-locking plate construct as compared to a hinge which is intact. And most of the times it is in the post-operative period that we realize that, oh, it looks like a hinge fracture. On the CM, we might be seeing it, we just ignore it. That's point number one. Point number two, because the locking plate construct is more stable, it does not allow later collapse. So late collapse is a problem with non-locking plating constructs, and late collapse is known to change alignment and then again fail early or late.
Thank you so much to all the presenters and the co-moderators. We'll go on to the next session. That's a coffee break, sir.
Yes. Any comments, Dr. Mittal, from you for this overall papers and the whole concept?
Yeah, that's a very nice concept, but there's always be a personal bias how to select those papers. And if you select a particular paper, something comes later on also. Like I was talking to him about the joint line obliquity. Yes, this has come in the publication that you don't want joint line obliquity, but subsequent papers have shown, multiple papers have shown that it doesn't matter. It doesn't matter at all if you have joint line obliquity.
Yeah. So I think this just goes on to show, you can find the evidence and the support for what you're looking for. Initially, when Sachin and me were making the program, we first thought that we should call it the 5 most cited papers in the last 5 years. So, but then we changed it to landmark papers. And you nicely told us, Srinivas, what is the difference. So I think this kind of papers just stimulate you. And to Raja's point, I think you have to read in between and get the message. I think that is what we wanted to highlight in this session. And I think the message is through. Yes, Srinivas.
Consensus papers actually filter the evidence and give us good directions for controversial issues. I think there are 2 papers on osteotomy as well from SKA consensus.
Yeah.
They're also very good.
Okay.